There's a new ADHD medication that hits 3 brain chemicals instead of 1. And I think it's going to disappoint a lot of people. Let me explain both of those things because they're connected. This is Simtriyo, generic name centanafadine. I think that's how I pronounce it. The first FDA-approved ADHD medication built specifically to hit 3 neurotransmitters at once instead of just 1 or 2. On paper, that sounds like a big deal. More brain chemistry involved, more systems working together. It should mean a better medication, right? Well, here's my honest starting point before we even get into all of this. I've watched patients try Strattera, Qelbree, 2 medications that offered a different approach when stimulants weren't the right fit. And in my clinical experience, neither one came close. So when I see a third non-classic mechanism showing up with the same kind of buzz, I'm not starting from excitement. I'm starting from skepticism. So the question is whether Simtriyo earns its way out of it or whether this is Strattera and Qelbree all over again. And who am I to doubt a medication built on 3 neurotransmitters when my own credentials are built on 3 board certifications? My name is Dr. Salman Aziz Mirza, triple board certified in adult psychiatry, child and adolescent psychiatry, and addiction medicine. And I've treated enough ADHD across the lifespan to know that a new mechanism and a better medication are often 2 very different things. Quick heads up before we go further. This isn't on pharmacy shelves yet, but could be in late 2026. DEA scheduling is still pending, so nobody watching this has real-world experience with it yet in late August. What we do have is trial data, and there are 3 completely different questions that people keep smashing together every time a new medication launches. Is it new? Does it work? And 3, is it actually better than what we already have? Those sound like the same question, but they're not. Simtriyo has a clean answer for 1, a decent answer for the second, and for the third, the one everybody actually cares about, we genuinely don't know yet. So let's start with the easy one. Centanafadine is what's called a triple reuptake inhibitor. Normally, after a neurotransmitter fires, your brain clears it away pretty fast. This drug slows that cleanup for 3 neurotransmitters at once: norepinephrine, dopamine, and serotonin. Classic ADHD meds already touch dopamine and norepinephrine. What's generally new is the combination. Simtriyo is the first FDA-approved ADHD medication specifically designed as a norepinephrine, dopamine, and serotonin reuptake inhibitors. One more thing worth knowing. Even though the mechanism sounds different from classic stimulants, the FDA still classifies it as a stimulant. It'll be a controlled substance once scheduling is finalized, most likely Schedule 3 or 4. So question 1, yes, it is new. But being new is the easy part. The question that actually matters is whether any of this translates into patients getting better. Centanafadine was tested in 4 separate phase 3 trials: kids, teens, and adults. Across all 4, it beat placebo at reducing symptoms consistently, and it was replicated. That's real. That's exactly the bar the FDA requires before granting approval. So if someone tells you it works, they're right. But here's the part that tends to disappear in that excitement. Works better than placebo and works better than Adderall are not the same claim. Nobody has run that second study. Not against Adderall, not against Vyvanse, not against methylphenidate, not even against Strattera or Qelbree. So anyone who confidently is telling you that it's better or worse than what you're already taking is making a claim that evidence doesn't support yet. And there's another wrinkle. In the adult trials, the average advantage over placebo was measurable, but not enormous. That's not a knock on the drug. It's just the difference between saying a result was statistically significant and saying patients experienced a dramatic change. And this brings us to the part of this medication I find the most interesting: serotonin. If dopamine and norepinephrine already explain so much of ADHD treatment, what happens when you deliberately add serotonin reuptake inhibition to the equation? Right now, we don't know. But there's an interesting early clue. There's a preliminary study in adults with both ADHD and anxiety where people on centanafadine improved on both fronts versus placebo. That's interesting, and it got my attention too. But even if that result holds up, we still don't know why it happened. Was it serotonin, dopamine, norepinephrine, or all three working together? The trial wasn't built to answer that, and neither can I, yet. So let me be clear about what this drug is not. It's not an antidepressant. It's not approved for anxiety. And nothing here says it should replace medications built specifically for those conditions. Researchers now have a new mechanism worth studying properly. And that's exciting. But excitement is not evidence. So now we have two answers. It's genuinely new, and yes, it works, which leaves the question I actually care about, and the reason I'm skeptical in the first place. Is it going to be any better than what we already have? Remember my bias from the beginning? Let's actually test it. Strattera and Qelbree offered a different approach to ADHD treatment, particularly for patients where stimulants weren't the right fit. And in my clinical experience, they underdelivered compared with stimulants for most patients. That's why I came into Simtriyo skeptical. But here's where the trial data pushes back on my bias a little bit. Centanafadine didn't just produce one positive study. The efficacy signal showed up repeatedly across multiple phase 3 trials and age groups. Does that mean it'll perform like a stimulant in real life? No, we don't have that comparison. But it is enough to make me less dismissive than I was when I first saw the mechanism. So my bias isn't resolved. It's just less confident than it was several minutes ago. That's genuinely where I am. Not sold, but not dismissive either. And if you're wondering why it might actually feel different for a patient, there are a few practical things worth watching. It is once a day. It'll be a controlled substance, unlike Strattera or Qelbree, which changes refills and how your pharmacy handles it. The side effects look familiar, but not revolutionary. Decreased appetite, nausea, headaches, trouble sleeping, and benefits were detectable by the first week in trials. That's encouraging. But again, there's no comparison study telling us whether that's faster or slower than what you're already taking. And then there's also misuse or abuse potential. People reported less quote-unquote drug liking than with amphetamine, but more than placebo, with similar rates of euphoria to amphetamines. So I wouldn't call this a lower risk stimulant across the board. I'd call it a different risk profile. And we'll learn more about that, how the DEA views that once scheduling is finalized. So we've now answered almost everything the current evidence allows us to answer. It's new, it works, it has some genuinely interesting differences. But the one question everybody wants answered is still sitting there. Is it actually better? So, back to the question I opened with. Is this going to be a letdown? Honestly, I don't know yet. And I think that's the most useful answer that I can give you, at least today. Simtriyo is a legitimately new mechanism with real replicated evidence that it beats placebo. That's generally good news for ADHD treatment. But new and proven better, not the same milestone. And a lot of the excitement right now is quietly skipping past that gap. My clinical bet, given what Strattera and Qelbree taught me, I'm not expecting this to dethrone stimulants for most patients. But I'm also more interested than I expected to be, because the evidence is strong enough that I'm not comfortable dismissing it before we see what happens in the real world. And here's the actual lesson, because it's bigger than Simtriyo. Every time a new medication makes headlines, the conversation immediately jumps to, is it better? And that's almost always the one question the evidence can't answer on day one. New deserves your attention. It doesn't automatically deserve your hype. And if you remember that difference, you'll read every future medication headline a little more like a clinician, like me, and a lot less like a headline. And I've mentioned Strattera several times in this video without actually walking through why it underdelivered for me. That's not an accident, because that's the video I want you to watch next. I'll break down what Strattera actually does, where it genuinely helps, and why my experience with it is one of the reasons I was so skeptical of Simtriyo in the first place. So if you watch this whole video waiting for the evidence instead of the hype, click that one down below next. It's linked over there. And until next time, be safe and be well.